Good morning, everyone. I want to welcome you to our program today with Dr. Ignacio Mata, or better known as Nacho. And he's going to be speaking to us about genetics and precision medicine, Parkinson's disease, and all kinds of interesting things. I'm going to read you a little bit briefly about him. Dr. Mata is currently an assistant staff at the Genomic Medicine Institute at the Cleveland Clinic in Cleveland. And prior to that, he was at the VA in Puget Sound, University of Washington for 12 years. And he's been working in the field of Parkinson's disease for nearly 20 years, which I find hard to believe. Yeah, so a lot of his research has been performing genetic studies in non-European populations, especially those with a minority ethnic background, such as Latinos. And for this, he created and coordinates the Latin American Research Consortium on the genetics of PD, a collaboration of more than 40 institutions in 14 countries in Latin America and the Caribbean, trying to identify the genetic risk factors associated to PD in these populations. And I could go on and on and on, but I'm going to let him talk to you rather than you listen to me the whole time. So with that, I'm going to turn it over to Nacho, and welcome, and look forward to hearing your talk.
Thank you, Sharon. Thank you so much for the kind introduction, and most importantly for the invitation. This is really a pleasure for me to talk to you all today. And before I started, so I just wanted to mention, it is true, I started studying the genetics of Parkinson's disease in 2001. It was part of my PhD thesis. It was kind of when the field of genetics in PD were starting. And I wanted to mention this because how I got started into Parkinson's disease, which is something that people ask me all the time, it's probably very unique. I don't think anybody shares the same story. So I got into genetics in college. I studied biology. I'm a molecular biologist by training. And when I started my PhD, my lab really had two research paths. One path was the cardiovascular disease, which is the #1 cause of death in the region of Spain where I'm from. And then there was a very, very tiny part of the lab that worked in neurodegenerative disorders. That included Parkinson's, Alzheimer's, all kinds of diseases. And when I was in college, I also fell in love with neurology and the brain. So I went that route just because of my interest on the brain and the power of the brain has. But also how complex those diseases that affect the brain are, because we don't have access to the tissue, or it's very hard to study. But the reason why I started on Parkinson's disease specifically is because there was a small Parkinson's support group in my hometown. My hometown has about 300,000 people living there, so it's not very big. It has a small support group that had probably around 500 members, maybe. So it's not too small for the small city that it is, but but it's kind of small. And they came to us, to the lab, and they were asking us why there were no more studies, more research being done in Parkinson's disease, and specifically genetics of Parkinson's disease. And we said, well, people don't really believe that there's a genetic component of Parkinson's disease, so they, governments don't want to put money into this. And I don't know why, but they had a feeling that this was going to be important to understand the disease. So the patients themselves pay me to do research. So basically, they were my boss for 1.5 years. They were putting money every month to pay my salary from their own pockets as a fellowship. This was really big in Spain. It was the first disease that had a fellowship funded only by patients of the disease that was being studied. So it was all over the news. And I have to say that this started in 2001, and this continues to date. There's been 8 different fellows, so the 8 different people that have gone into the research of genetics of Parkinson's disease because of this fellowship from the patients. So I wanted to tell you the story because of the power of the patients, and when you guys want to do something, it happens, So not only as participants, but also as as a movement of trying to get the things done is very powerful. And I think it's a very cool story that I thought I would tell you just to so you get to know me a little bit better. Yeah.
Wait, I'm going to show you the power of the patient. Our patients want to know if they can get the slides.
Yes, absolutely.
Okay.
Yeah.
All right, ladies, we got what you want. Okay, I'm going to be quiet. Put your questions in the chat. We are paying attention to it. So.
Yeah, and if there's something that you think that you need to know to understand what I'm talking about, please stop me and just ask the question, because I don't want to lose anybody. Okay. Although I heard that this group is full of very smart women, so I'm going to skip through some of the basic stuff about genetics. So if we have questions about this, I can go. I still have the slides. I won't show them, but we can go back and I can explain some of the terms if there's anything that you guys want to know more about. Okay, but I wanted to have some time to discuss at the end, so my presentation will be kind of brief. All right, so this is my overview. So again, I won't mention a lot of the genetic concepts. I think I have one slide about this just to tell you something that I think it will be important for when we talk about the genetics of Parkinson's disease. But mostly, I want to tell you what we know about the genetics of Parkinson's disease in this, again, 20-some years that we've been studying it, and then how I think we can use genetics in the clinic and beyond, and that's what Sharon was referring to, a precision or personalized medicine, which I think that's one of the goals that we have as geneticists, is to be able to apply what we're finding in the lab to be able to translate this to the clinic for better care for individuals with Parkinson's disease. And then at the end, I'm just going to mention a little bit about what my lab in particular is doing about trying to increase diversity in research, which is very much needed. So just to start, I wanted to mention something that for all of you, I'm sure this is very obvious, but Parkinson's disease is a very heterogeneous disorder. What does it mean? It means that if you have 10 individuals with Parkinson's disease in one room, it is very possible that none of them look alike. And it's probably also likely that the story is different. Like they've got the disease at a different age. They probably have different symptoms. Even at the start of the disease, they probably had a different symptom. Some of you might have non-motor symptoms. Some of you might not. Some of you might feel like you're not progressing and you're very well maintained with the medicines, while some other people might feel like the medicines are not working as well, or they're progressing much faster. From the point of view of the brain, we know that the brains of Parkinson's disease patients, although they have things in common, they're actually very different. There's a lot of things going on in the brain. Also, family history, which is something that obviously for me is very important. We know that only about 20%, and I'll mention this later on as well, about 20% of the patients report another family member affected. But there's people where they have large families where a lot of people are affected, and there's people that they don't have nobody in their family that have had Parkinson's before. And those that have family history, we know that in terms of genetics, the inheritance, or the way that this disease is inherited from generation to generation, is very different. So in some families, we see individuals affected in every single generation. In some of them, it looks like it skips some generations. And in some of them, looks like only the males, for example, get the disease, but no females. So one of the things that puzzles us is that why is Parkinson's disease so different in people? It doesn't. There's not that many diseases where this is so obvious. And I like to put this drawing that came out I think a year ago, just to and again, this is something for this group. It's probably very obvious, but we need to get rid of this view of Parkinson's disease being an all-white man disease, because it comes in all different shapes and sizes, right? So there's women, there's young people, there's people that are non-white affected by the disease. So we have to keep this in mind when we study the disease, and this will become very important about the diversity that I was mentioning at the end, and also about the project that we're doing with women. Again, it's something that I think for many years we didn't keep in mind, and that's why the research that we that we have done in the past is so white, male oriented, which is something that we need to change. So I think one of the reasons why this disease is so heterogeneous is because there is many different ways to get it. And this is only the things that we know, but we still don't understand very well how this happens. So for example, we know that, the older we get, the higher the risk is to develop Parkinson's. The same thing with other neurological disorders like Alzheimer's, for example, other dementias. And we also know that males have about almost twofold increased risk than women to develop the disease. In addition to that, we also know that there are certain environmental factors like exposure to heavy metals. So people that work in mines, living in rural areas, being exposed to pesticides, certain pesticides, drinking well water. And I think in the last few years, there's been a big push for things for like head trauma, for example. So individuals that have jobs where, they get hit, especially concussions where people actually lose conscious, seems to be playing a role. And this might be related or not to an important role that we know inflammation plays in the disease as well. Another hot topic that is being studied now a lot, not only for Parkinson's, but for many diseases, is the microbiome. What is that? Is all the bacteria and fungus and all the things that we have in our stomach that helps us digest food, and absorb certain nutrients. But that they play a role also in the risk that we might have to develop certain diseases. And in Parkinson's disease, as a lot of you might know, we think it starts in the gut about 20 years or more before the first symptoms start. So it means that anything that has to do with the gut might actually be very important to kind of jumpstart the process of the neurodegeneration. So this is a very hot topic that is being studied a lot right now that we still don't really fully understand. And then exposure to viruses. That's how Parkinson's disease was kind of was found in in the flu pandemic. And now there's a lot of studies very interested to know how COVID-19 actually and these infections that we're suffering right now are going to affect the risk for developing, again, not only Parkinson's, but a lot of neurological and neurogenic disorders. So all these things play a role. In addition to that, we know that there are certain things that are protective, smoking and caffeine being the most studied ones and the more replicated ones. Again, I always have to put this disclaimer that smoking might protect against Parkinson's, but I give you lung cancer. So it's you decide which one, which route you want to go. So I do not recommend people picking up smoking. And caffeine is also, you have to do it in a you can't just go and drink 20 coffees a day. That's not how it works. Everything has to be balanced. We already mentioned exercise. Exercising might not actually be as protective. We still don't really know, but we know that for progression and to help with quality of life is certainly probably the most important factor that we know it helps patients with Parkinson's disease. And then also anti-inflammatories. And this, again, this relates to what I was talking about, the risk factor of inflammation, and especially inflammation on the brain. So we know through epidemiological studies that individuals that take routinely, sometimes for other diseases, anti-inflammatories seem to have a lower risk. It doesn't mean that you won't get it, but it means that it lowers your risk. So again, we have things that increase your risk, things that lower your risk, and then we have genetics. And as I mentioned, until the 2000s, really, people didn't believe that there was a genetic component, and this came mostly from twin studies. So you can imagine that if a disease is genetic, if you have two twins that are completely the same, so homozygotic twins, you would imagine that if one gets Parkinson's, the other needs to get Parkinson's because they have exactly the same genetic information. So what we do in these studies is we compare monozygotic twins with dizygotic twins, which only share 50%, and we see if there's more cases, concordant cases, so more twins that are monozygotic that get the disease at the same time, than the zygotic. And these studies actually show that it didn't seem to be a big difference, which kind of pointed to the fact that there was no genetic component for the disease. However, this study had a follow-up study 10 years later, and they showed, which again, as I mentioned, is very heterogeneous, and age of onset is very heterogeneous. They show that in a lot of the couples a lot of the twins where one of the twins was sick and the other one wasn't, the second one actually became diagnosed with Parkinson's disease within those 10 years, much more on the monozygotic group than in the zygotic group, which means that there is a certain genetic component. And then I think this study in 2002 was probably the first one that really showed that there is a genetic predisposition, because if you have an affected member in your family, we know that your risks to not have Parkinson's is much or to avoid Parkinson's is much lower, and especially in those cases where the individual got the disease before the age of 40. So we know that early, the earlier you get it, probably the larger the genetic component it is. And again, early onset or even young onset Parkinson's disease usually has a much important genetic component than late onset Parkinson's disease. Okay, this is important to have. So you see that from the point of view of what causes Parkinson's disease is very complex. So you can now starting to imagine why we think that Parkinson's disease is so heterogeneous, because maybe somebody got it because of pesticides, somebody got it because of pesticides plus concussion, somebody might have two of those, but then he has a protective one, so he never develops the disease. So the combinations are almost unlimited, right? And again, this is only for the things that we know. There's a lot of things I think that we still don't know. So in terms of genetics, as I mentioned, in most cases, this blue piece of the pie, which is the largest, that has about 80% of all individuals with Parkinson's disease, are what we call sporadic. It means that if you ask them, the patient will say that they don't have any other family member affected with the disease. So they're just the solely individual with Parkinson's in their family. And then we have what we call the familial form, which is about 20%. And within the 20%, there's very, very little. So this becomes like maybe 5% of all the cases, maybe even less than 5%, where the disease is caused only by one gene. So that means that we can actually predict in that family who might get the disease and who doesn't. So in terms of being genetic, like you can imagine, for example, a genetic, in this case, it's not a disease, but it's a trait, like, for example, blood type. So blood type is controlled by one gene. So, well, two genes, if you think about A, B, 0, and then the negative and positive, right? But you know that if you have the information for the parents, you know exactly what the kids are going to look like in terms of blood type. So in Parkinson's disease, there's very, very few patients where we can actually do the same, because in most cases, the genetic component is much more complex than just one gene controlling it. And in fact, studying these 20% of familial forms, and you can see a family here where, there's a clear segregation where the disease runs in the family generation after generation. So studying these type of families, we've identified more than 20. I think we're up to like 25 now, 25 different genes that a variant in this gene can directly cause the disease. But a lot of these might happen in one or two families in the entire world. I put here in blue the ones that are the most common. So synuclein, Parkin, PINK1, DJ1, LRRK2, BPS35, and then GBA are probably the most common genes. And if you know about PD generation, the Parkinson's Foundation initiative where they're screening for 7 genes, these are the 7 genes that they screen for, because they're the most common. That means that there are people all around the world that might have similar variants in these genes, and their Parkinson's is caused by a variance in this gene. For the rest, there are very, very few families in the world that actually carry a variant, so they're not very common. Okay, so this is what we know about familial forms of Parkinson's disease. And you say, well, at least for these families, you know, it's easy to know, right? There's not that many, but at least for this we can tell. Well, things are not easy or as easy as we would hope. And in fact, once we started studying some of these families, we realized that there are people with variants in these genes that can live up to, like in this case there were 90, in this case there were 80 that had the variant and never developed the disease ever. They didn't have any symptoms whatsoever. The reason why is we don't know. There might be other genetic factors that might be protective in these individuals, or there might be some of the environmental factors that are protective that might actually help these individuals not to get to the point where they develop the disease. And there have been many studies trying to understand what is actually the risk then of having one of these variants. And the reason why is because many companies, as soon as we found this variant, starting testing for this variant and reporting the data back to the patients, which again, when you don't really have an exact number of what is the risk when you carry one of these variants, it becomes very complex, right? So the largest study that was done in 2008 with more than 20 centers worldwide, more than 1,000 individuals that carry this specific variant, we came up with a number that is about 74%. What does that mean? It means that if you have this variant and you get to live all the way to 80, your risk to develop the disease is about 75%. What does this mean is that if you are in your 30s and you get tested, you don't have the disease, and we find out that you're positive, you might have anywhere between 0 and, I don't know, 50% risk to develop the disease. But we don't know if you will, and we don't know when you will get it, which, as you can imagine, to do counseling on these individuals is very hard. So we still need to find what are all the other things that modify why somebody might develop the disease or not. So in addition to that gene, there's another gene that is also very complex, and that is the gene of it's called the GBA, or the glucocerebrosidase, and this gene is the gene that causes Gaucher disease. So Gaucher disease is autosomal recessive lysosomal storage metabolism, so it has nothing to do with Parkinson's disease in theory. And this is being recessive means that an individual has to have a variant that came from their mom and a variant that came from their dad, and when those two get together in one individual, that person develops this disease, which is not deadly. At least most of the variants are not deadly, but it's a disease that needs to be treated. And what we found was that in those families, when you carry only one variant, which again doesn't cause Gaucher, your risk to develop Parkinson's is increased by 6-fold. This puts this gene into the biggest genetic risk factor that we know. This is, if you're familiar with the Alzheimer's, this is like ApoE E4 for Alzheimer's. This is our ApoE gene. So it's very complex because, again, there is this only increases your risk by 6-fold. So it means that it's even harder to predict than these familial genes that I was telling you about, to decide if somebody is gonna develop the disease or not. And there's certain populations, like for example Ashkenazi Jews, who had a much higher frequency of this variant. And about 5 to 10% of Parkinson's patients all around the world carry a variant in this gene. And this is very important because although it's very hard to use to predict who is going to develop the disease, we know that the people that carry this gene that has been diagnosed with Parkinson's disease is going to have a very specific form of Parkinson's disease in terms of age of onset, in terms of progression, and in terms of symptoms, especially non-motor symptoms that these people are going to develop. And I'll talk to you about this in just a minute. In addition to that, there are many other genes that have a much lower risk than this. And the way we find these genes are comparing very large group of individuals with Parkinson's disease and also match healthy controls. So people that are almost in the same age range and are from the same gender. And by doing this, the last bigger study, the biggest study that was done in 2019 included about 40,000 individuals with Parkinson's disease and about 1.5 million healthy controls. That study identified 90 different variants in 78 different genes. So there are 78 different genes in addition to the 20 some that I already told you about that, again, don't cause the disease, but increase your risk of the disease. And again, they increase it by maybe like, I don't know, 6% or 15%, but not significantly. So you can imagine that just having one of these variants, and probably everybody here in this call carries several variants in several of these genes, doesn't mean that, you know, we will develop or that was the cause of our Parkinson's disease. But you can imagine that being so many, when you start adding up all these, they all count, and each of them moves you closer to the threshold where you might develop Parkinson's disease. And in fact, that's what we see when we study these in a term we call polygenic risk scores. And I think I have a slide. If not, I'll dig it up. It's explaining how this polygenic risk score works. But then, just to summarize, what we know about the genetics of Parkinson's disease is that there are at least 3 different groups of genes here. And here I represent the frequency of the variant in the normal population. So the farther we go to the right, the more common these variants are in the normal population. And here we call it the penetrance, or the possibility or the probability of somebody that has a variant in that gene to actually develop the disease. And you can see that there's different groups here. You see the families, which are genes where variants are very rare, but they have very large penetrance. So if you have one of these, you more likely will develop the disease. But the majority of the genes are on this group, where the frequency is quite high in the normal population, but the effect is very small. And what you need to do is you need to have a lot of these different variants, and in most cases, together with some environmental factors, to actually reach the point of getting the disease. And I like this figure because it kind of explains it really well. So imagine that, you know, when you're born, you are born with this specific genetic risk, which are the orange balls, right? And everybody is born with a certain risk for not only for Parkinson's, but you can extrapolate this to any disease that you want that has a genetic component. So you start already with some balls in this cup. The line is where you will start feeling symptoms for Parkinson's disease. And then as you start aging, and as you know, as you go through life with all the you know, exposures that you get, all the life events that happen to you, you start adding more risk variants or more risk factors, right? To a point where you know, the cup overflows, and then that's when the first symptoms start to appear. So we have to keep this in mind. And I always tell people that unfortunately with the genetics, there's nothing we can do about it, but there are lots of things that we can do about the environment, right? So living a healthy lifestyle, exercising, all those things are making that we're not adding more risk factors to this cup to the point that we're gonna overflow it. And all these genes, they all tied on different pathways, so on different activities that the cells have to that they have to do. And many of these genes are in the same pathway, but there's at least 3 or 4 different pathways that we know. One could be the energy production. The other one is the cleanup of proteins that are no longer necessary. So all these genes can actually be put into these pathways, and kind of explains a little bit better what the biology is of why the dopaminergic neurons, which are the ones that die in the brains of individuals with Parkinson's disease, why this happens. And it's because, again, you have multiple hits in all these different activities that the cell needs to routinely do, and it can't do successfully anymore. Okay, so then what do we use genetics for? So obviously you can imagine that it's really helping us to shape what we know about the disease, and that always translates into, you know, better treatments and all those things. But In terms of diagnosis, we don't use genetics. Movement disorder specialists, neurologists are very good at diagnosing Parkinson's disease. They don't need a genetic test to know that somebody has or doesn't have Parkinson's disease. We do use it in certain cases. For example, somebody that has a family history or somebody that gets the disease very early, because if we identify one of these familial genes, we can actually, in many cases, predict what the risk is going to be for the descendants of that person. So this is an important thing. But in my mind, the most important part of this is the prognosis. So if we identify what the cause for your Parkinson's is, and if it's genetic, we can compare other patients that have had the same variant, and we can put you in a subtype of Parkinson's disease and kind of tell you what your disease is going to look like. Like, am I going to progress really slow? And maybe, my symptoms will be very well maintained. Am I going to develop cognitive impairment and dementia very early on in the disease? Those are things that can be used. It might not change the care that you will receive, but at least it can help you prepare. So if you know that you're going to have cognitive problems, you might want to start, making some decisions early while you're still, fully able to be able to make important decisions, financially or with life or all those different things, right? So you can imagine that some of these things might be very important for the individual that has Parkinson's disease. And then the two last points are, to me, so prognosis, I think, is the short-term utility, but I think eligibility for clinical trials, and especially the precision medicine, are maybe the next things that I think we're going to use. And one of the reasons is that you can imagine that, again, each subtype of Parkinson's disease. So once we figure out what is your specifically the cause of your disease, not the Parkinson's disease in general, but your individual disease, we can actually use that to decide what is going to be the best treatment for you, and also design drugs that are specifically for those individuals. Because as you well know, there's been a lot of different clinical trials and none of them have been successful. So we have not been able to find new treatments for Parkinson's disease for many years, although we have tried to do this. And a lot of the people, including me in the field, we think that one of the biggest reasons of why this is not successful is because we're pulling patients that all have Parkinson's disease but have very different causes. And it means that we're trying to find a cure for or a treatment for everybody, and that's going to be very hard to happen. I think what will happen is that there'll be very different treatments for different causes of the disease. So if you have a certain gene, then we need to fix that gene. We don't have to fix all the genes, right? So I think that this is very important, and this is already happening. So there are already clinical trials on phase 2 treating actually 3 of the genes. So synuclein, GBA, and LRRK2, they all have ongoing clinical trials. So that means that if you get genetic tested and you know that you have one of these variants, you should participate in these clinical trials to see if this drug actually help your type of the disease, because it might not help every patient, but it might help your Parkinson's. So we need to keep this in mind. And I'll go through really fast of this a few slides so we have time to chat, but I just wanted to tell you about the prognosis. So we already know, for example, that people that have mutations or variants in synuclein have cognitive problems much more often than people that don't have mutations in this gene. And there's many studies where they show that, within a few years, these individuals will develop dementia. So there's something that we know in addition to the GBA gene. Parkin genes, for example, this is a recessive gene that causes early onset form of Parkinson's disease. So about 50% of people that have the disease before the age of 40 will have one of these genes or a variant in this gene. And we know that these individuals actually have very slow progression, and in very few cases they will develop a cognitive impairment. So it's a much milder disease, for example, than synuclein or GBA in terms of progression. And again, this has been validated in different studies. The same thing we can say for LRRK2. So for LRRK2, we know that in terms of cognitive impairment, for example, measured here by the MoCA, We know that they have a much better prediction for cognition. So cognitive function is much well maintained in these individuals, and also progression is slower. So if you happen to have a LERC2 variant, the Parkinson's disease that you're gonna develop is much different than people with others. Again, GBA we already know, and interestingly in GBA, not only is it important to know that you have a variant in GBA, but what variant, because there are different levels of variants, and some of them have a much faster progression and much more cognitive problems than others. So it's important to know. And again, if you participate, for example, in a PD generation on any, well, that's the only really study that is returning data to patients right now. You will get this as part of your genetic counseling. That will explain not only that you have a mutation in this gene, but what mutation and what that means to you. And something that we are exploring here, there's a few studies already ongoing, showing that, for example, GBA carriers, so the individuals that have variants in GBA, do not respond as well to DBS surgery. So my goal, or our goal, I think, is to be able to use this information to also decide if somebody is a good candidate for DBS, for example, or for some of the other treatments that are available for Parkinson's disease. And again, this is really all part of this precision or personalized medicine that is already being done in cancer and other diseases, and that must happen also in Parkinson's disease. And I think this really summarizes it all. Right now we have the traditional approach, which is the one pill fits all. So you go through the clinic, you get diagnosed with Parkinson's disease, you're gonna get the same treatment regardless of where you are and who you are. And the idea is to use the genetic information, right? And the treatment in the traditional approach will work really well for some people, but might not work as well for other people. So the idea is to use the genetic to classify people into different subtypes, and then depending on what subtype you have, then decide what is the best treatment to do and to use. And I think this is going to be the future, and I'm hoping that it's not going to take that long to get to that point. And as I said, there are ongoing clinical trials. These are the ones that are for GBA and LERC2. Most on phase either 2 or 1. So we're still looking to make sure that this is safe for the patients to take. But I think, especially in the GBA case, I think we're moving much faster, because GBA, as I mentioned, is a gene that causes a different disease that has been studied for many years. So there are already FDA-approved drugs that we can use, and they are being tried on individuals with Parkinson's disease. So I think we might get, the GBA might be the gene where we might get closer to do this precision medicine sooner than any of the other ones. And just to finish, I wanted to mention like 3 things about increasing diversity in research, especially in genetic research. And this gives you an idea of how poor of a job we're doing as researchers to try to include individuals that are non-European. This is the total of all individuals included in genetic studies all around the world. You can see that more than 80% are all European. And unfortunately, most of the rest of the, to get to 100%, yes, so there are studies from Asia. So that means that individuals from Africa, the Caribbean, Hispanics and Latinos, or other individuals are very, very underrepresented. And this is a problem, because as you probably hopefully know by now, the causes of the disease are very different, and you would imagine that individual people with different ethnic groups or from different ethnic groups might also have different causes of the disease. So this is going to increase the disparities that we already have in clinical care. So we need to do better studies, and that's why we created the large PD study, which Sharon already mentioned, that has many sites all across Latin America and the Caribbean. And we also have a branch now here in the US where we're trying to recruit Latinos also in many other regions of the US as well. And then the last slide, the last couple of slides, is the project that I was mentioning at the beginning, which is another underrepresented group in research, not because they don't participate, but because we're not collecting the right data, are women. So women participate in research as much as men in most cases, but we know that women have less risk. I already mentioned this, but when you get Parkinson's disease, the Parkinson's disease subtype is very different. In many cases, the non-motor symptoms are even more important than the motor symptoms. So a PhD student in my lab wanted to understand why this happens. So Shilpa, the first thing that she told me when she came to my office, she said, well, I know why we don't have more data on or we don't understand why women get Parkinson's in less, less prevalent, and why they have different Parkinson's. She said, I just went through every single questionnaire that we use. And she said, and we don't collect any data on women's health or anything that is specific only to women. Like our surveys and all our questionnaires are completely gender neutral. She said, we're missing a lot of data here that is probably very important to understand this. And we already knew that hormones might be very important to perhaps protect women until menopause to develop the disease. So what the first thing that she did is she developed a questionnaire, which is now available, and the paper just came out 2 days ago, that collects all this information, not only information about women's health in general and all the women's events, including pregnancy and birth control, all these different things that are specific to women, but also how they affect the disease. So do your symptoms improve? Do they get worse? What kind of symptoms is it? The non-motor symptoms, the motor symptoms? So I think studies like this, which I know that there are several groups working on similar surveys, I think they're really going to help us to try to understand better Parkinson's disease in women. So with this, you already know about this, so I don't have to sell it, but the World Parkinson's Congress in Barcelona 2023 is going to be amazing. It's the only meeting in the world for Parkinson's disease where we have the chance to interact with patients, clinicians, researchers, and patients sitting in the same room, which to me is the right thing to do to really move forward and make sure that we all go in the same direction. So with that, I'll stop here, and then hopefully we'll have some good questions and also some good discussion. And if there's anything that I can explain better, and I'm sorry I went kind of fast, if there's anything that I can explain better, I'll be happy to do so as well.
Wow, that's all I can say. That was a lot to present in a very short time. When I was in Israel several years ago, I met with the director of the Sourasky Hospital Center for Excellence for Parkinson's in Tel Aviv. And she was telling me about the research they were doing there on GBA, because they have such a huge Ashkenazi population that they can really do a lot of research, and they were looking into gene therapy as a treatment. And one of the questions that came up was where are we in that process? Are we getting anywhere with gene therapy, CRISPR techniques, whatever it may be? So that's one question. Let me just give you the others real quickly. There was another question about the LRRK2.
Well, let's answer that question. So as far as I know, it's moving, but it's moving slow. And I think it has some potential, but again, you have to remember that GBA only increases your risk. So by itself, it doesn't really cause disease. So even if you fix that, there's probably other things that are together with GBA that make somebody, as I mentioned, overflow the cup and go to be diagnosed with Parkinson's disease. And I think gene therapy, just targeting specific genes is going to be very hard, because as I said, there could be potentially 150, 200 different genes that are involved in Parkinson's disease. We will not be able to fix them all. One way that they're trying to do is they're trying to use gene therapy, for example, to protect the neurons, giving the neurons some extra boost in terms of the things that the neurons need to work better to perhaps deal with these errors. When these genes go wrong, to deal with that much better. Because again, the disease usually starts about 20 to 30 years before the first symptoms start. So that means that the brain at some point is dealing with it, okay, right? It's just together probably with aging, we get to a point where the cells said, I can't work like this anymore, and then they kind of give up, right? So I think the gene therapy might help trying to keep those neurons happier and giving them what they need, maybe even reversing the process of aging a little bit. So maybe we don't need to fix GBA, but it is a possibility, and I think we need to explore it. But I don't know if that's going to be the solution, because as I said, there's so many different genes involved, even within GBA. what models that and what modulates the risk for that. Again, there could be other genes involved that you will not be fixing. So.
Okay. All right, let me start going through the questions then. Farrell wants to know about the progress of developing a medication for people with the LRRK2 mutation.
Yeah, so as I show, the most of the clinical trials on phase 1 right now. So they're looking to make sure that they're safe. LRRK2 is a very complex protein because it has at least 5 different protein domains, which means that potentially it could be involved in many different activities. Most of the mutations are in the kinase domain, which is the one that phosphorylates and kind of activates or deactivates other proteins. So the mutations, what it causes is an overactivity of that kinase. So it kind of phosphorylates more things than it should. So they're using kinase inhibitors to try to bring the level down of the activity to a normal level back again. So I know that there's quite a few things being tried on that route, but so far we don't have any results that if it works or not. But the nice thing is that it is targeting this specific population, and the individuals that are participating in these clinical trials have variants in this gene. So again, this might not work for all, but it might work for people that have variants in LRRK2. Yeah.
Okay. Is there anywhere they can go to find out if they can participate in the trial, the GBA or LRRK2?
Yeah, there are many places. So clinicaltrials.gov is the website from the government that has all the clinical trials, and it'll tell you if they're open, if they're enrolling, if they're just analyzing data. The Fox Finder as well, the Fox Trial Finder in the Michael J. Fox Foundation grant website, it also helps with that. I think most of the foundations, the Parkinson's Foundation, the Michael J. Fox Foundation, all of them, if you call them, or even in the websites, a lot of them have a lot of information about this. But we do have to do a better job, I think, of advertising this. And I think projects like the PD generation, where the patients will themselves have this information and will be able to look for specific trials that kind of fit their Parkinson's, will make this easier, I think.
All right, next question from Marilyn. Both of her children have IBS and one has Crohn's. Are they at greater risk for Parkinson's, and should they be tested to see if they have a genetic link?
Yeah, that's a very interesting question, because there are a few things that come together more often with Parkinson's than other diseases, and one of them is Crohn and IBS, and in fact LRRK2 is involved in both of them. So it is possible that there is some kind of a variant in LRRK2 that will increase the risk for both diseases. The other one is also melanoma. There's an association. There's an increased risk for certain cancers and in individuals with Parkinson's disease, and this could be genetic or it could be also environmental. So. Yeah, I mean, again, it's hard because these genes they just increase the risk. They don't cause, or some of the variants, I would say, in these genes don't cause the disease. But I mean, it would be interesting to get tested and see if a gene that is involved in Parkinson's disease and in Crohn's might be the reason why. And if that's the case, then yes, then it will increase the risk to develop Parkinson's.
Sandra, I'm not quite sure I understand your question. As a child, what does constipation reveal?
As a child, as far as I know, I don't think there's any link from constipation in children. I know that it is a symptom that happens in Parkinson's disease, an early symptom perhaps. But yeah, I don't know if there's a link between people that have been a lot of constipation as a kids or not. I'm not aware of any studies with that. Yeah.
All right, Sherry, yes, we will send you the link to the the study that his lab student, I don't know what you call it. We will send the link for that study out. And she wants to know, should all PD studies now collect genetic and gender information for later in-depth research? I would think so.
Yeah, absolutely. The problem is although it is getting cheaper, it's still fairly expensive. to do this. So, you know, I think the standard use is this is in the clinical care. We're still a little bit far to be able to do this, but especially in institutions where there is research, ongoing research, we do this. Like here at the clinic, we certainly collect all that information, but yeah.
Francis wants to know which gene is associated with melanoma.
Well, there's several genes. So the PINK1, Parkin, there's several genes that are associated with cancer in particular, but I don't think we know what the association between Parkinson's and melanoma is, because those genes that I mentioned are quite rare. However, the association between melanoma and Parkinson's is much higher. So I think there might be other genes. So what we need to do is we need to study a large cohort of Parkinson's patients that also have melanoma and study their genetics and see if we can find. But so far, because that group is kind of small, I believe there hasn't been any studies yet. We know that the association exists. I don't think we know what the cause is yet. But again, there are certain genes in familial forms of Parkinson's disease that have been associated with cancer as well.
That's all that I had in the chat. Does anybody else have questions? We can just raise your hand. If you go to reactions down below, you can click on hand raise. Or just unmute yourself. Nobody?
I've got a question.
Oh, okay, great.
Okay. I was exposed to TC at a great level while I was in the military in the 80s at Camp Lejeune. It's very historic research and evidence-based connection. I wonder if there's any passed down to my children genetically, because this was something that was environmental that inflicted me. Could it somehow modify my epigenetics, if that's what it's called, or if I'm using that in the right term?
Yeah, that's a perfect term. Yeah.
Okay, help me understand how my genes are changed, like the DNA changes and replicates and could potentially, you know, pass down to the kids that I had later.
Yeah, so we don't know for sure if because epigenetics is a field that is very right now it hasn't been really exploring Parkinson's disease. It's been exploring other diseases. I don't think there has been as many studies as perhaps we need to for the disease. There are two ways that this could be passed on. In most cases, environmental factors only affect the individual that is exposed. So, for example, pesticides, some of those things. In most cases, that doesn't translate to something that it will get passed. But there are two ways that this can happen. One is if certain things might change your DNA itself. So it could create mutations, and there are compounds out there that can create mutations in your genome that you know, that can perhaps be passed, but those are very few because it might change your somatic cells, but not the cells that will use to reproduce, right? So those ones are much harder to change, and they're much protected. So in most cases, that doesn't happen. The epigenetic thing that you're mentioning, that is something that it is a possibility, and it doesn't really change the information, but it changes how the information is passed to your kids. So basically, what happens in epigenomics is that there are certain compounds in the DNA that folds the DNA in a way that some things become accessible and sometimes it doesn't. Other things don't come accessible, and those things are the ones that can change with the environment. Again, in Parkinson's disease, we don't know how any of the environmental factors affect the epigenetics. But if they do, it is possible that that could be passed on. And I know that there are several studies within the VA, for example, that are trying to understand this, because Agent Orange is another substance as well that increases your risk by a lot of Parkinson's disease. And we don't really still understand if it's something that is only for the person that got exposed, and if it somehow it kind of gets passed on. But in most cases, I would say it doesn't. Yeah, it doesn't get passed. Yeah.
Mm-hmm. Okay. Thank you.
All right, a couple more questions, and then we're going to wrap up. Is there a paper about GBA and the prognosis? that we can?
Oh, there's many. Yeah, GBA is probably one of the genes that has been the most studied in the last 5 years. So there's a lot of different papers about GBA. One of the I don't know if it's included. Hold on, I think I had a slide here, but so the Movement Disorder Society has a database. Let me see if it includes GBA. No, they didn't include GBA. They only included the familial. But you know, a lot of them, what they've done is that they compile all the studies that have been done for a certain gene, and then it tells you how many patients that has the gene has different symptoms. So yes, based on that, you can kind of figure it out what your disease will look like if you have a gene. But yeah, there's many papers. I can send one of the latest references for people to read. Yeah, just remind me.
All right, I have two questions that are related, and these will be the last ones. I understand most inherited Parkinson comes from immediate family. Is it possible for this to include other families? I have two first cousins, both on my father's side, that have Parkinson's. And I'm in the same situation, and we tested, and we do not have it. We do not have the gene. But the other one, like Deborah, I just found out that a first cousin on my mother's side has Parkinson's. When I participated in a gene study a few years ago, I was told I do not have a genetic link. So I guess the question is it first cousins or is it just siblings?
Right. So yeah, it's a complex question, because as I said, different genes get inherited in different ways, and they can jump generations. But also you have to remember that in most cases it's not only one gene, right? So there's other genes that have to come together, and a lot of times you might have the genetic predisposition, but then you also need an environmental factor, right? So it is very possible that a second cousin of yours have the same genetic variant that you have, and that's why you both got Parkinson's disease. But usually when we study families, we make sure that, you know, the families is usually first or second degree relatives that have, you know, that the disease kind of pass on, because otherwise it's kind of very hard to tell if it's genetic or not. The other thing that we need to remember also is that Parkinson's looks like it passes on familiar members that are close by, also because you share the environment. So in addition to also share the genetics, you also share the environment. So if there's an environmental factor, this will add to the genetic predisposition. So I think that's something to keep in mind. And what was the second thing, or did I answer?
It's related. Laura Russell had her hand up, which I didn't see. Laura, go ahead, and then we're going to wrap up.
Oh, you're muted.
Yeah, I think this question might be related. You may have just answered the question for me. I'm a bit skeptical that only up to 20% of cases of Parkinson's are genetic or inherited, because when I get into a group like this, if I asked how many people have a first very close family member who has Parkinson's, that all the hands go up. It seems like everybody has a close relative. My mother and two uncles have it as well. So this 20% number seems so low compared to the real life number of groups that I've been into where people self-report high incidence. How do we interpret that? Do you have any ideas?
There could be many reasons. I can tell you that those numbers come from very, very large studies in different parts of the world. This is epidemiological studies where we usually ask first or second degree relatives, so we don't go further than that. It is possible that, you know, in certain areas might be underdiagnosed, and maybe those numbers could be higher in certain areas or maybe in certain populations. So for example, if you're Ashkenazi Jew or if you're Berber, you know, in those cases, those numbers go up a lot because, you know, they share a lot more genetic information. There seem to be a bigger group of people that have inherited these variants. So LER2 and GBA are two of the variants that are more common in Ashkenazi Jews. It could also be that people that have other family members are more lean towards attending some of these support groups, while if you don't have any family member, maybe you're a little bit more alone, or maybe you know less about the disease. I don't know. I think there could be a lot of reasons, but this has been validated in many different places, and our studies in Latin America shows about the same. It's about 23%. And it doesn't mean that those are the genetic causes, but those are the people that have a family, family history. I think that everybody has an underlying genetic cause that might increase your risk by a little bit, and some people might be the only cause for Parkinson's disease. I think genetics play a role on everybody, but yeah, I think those numbers you should believe it. I think they are real.
Okay, thank you.
Uh-huh.
Yeah, I was going to say, I think that this group is self-selecting. So these are the people who really want to know, and it may be because they have family members, and we don't know. Anyway, thank you. This was wonderful. Can everybody? Thank you so much. It was terrific. We will send out the recording. We will send out the slides in the next few. It'll take a couple days before I get my act together. And let's see, Ashlyn, can you put up the slides so we can tell you what's going on? Okay, so I took a break. My shoulder is healing. Yay, I can raise my arm almost all the way. Thank you, physical therapy. So we have a lot coming up. I have 3 programs scheduled and a whole bunch more that I'm waiting to get scheduled. First, on June 5th, in 2 weeks, we are going to be doing the I Am poem workshop with Ashley Astley from PMD Alliance. The I Am poem is, you're not going to be writing a poem. It will be a writing workshop, but these you will be asked to send your poems in, and they will be on display with the tulips in Barcelona at the World Parkinson's Congress. So it all ties together. On June 26th, we're going to have Sue Wiley and her hilarious short film, What a Load of Balls. And if you haven't watched it yet, I've sent out the link last week, I think. Make sure you watch it. It is so much fun. And then on July 24th, Saba Shahid, who talked to us about micrographia, combating micrographia, will return with her Smile with Art program, which is art therapy for Parkinson's. So we'll be doing art. It'll be a fun day. Spell check changed it. It's supposed to be improv for Parkinson's, not improve. I have to fix that. And then we have some other things coming up. I'm hoping to have Eli Pollard, who is the executive director of the World Parkinson's Congress. I'm hoping she will come speak to us as well. Next slide. Ashlyn, next slide. Okay, so the open mic and open chat, open mic chat and open mic workouts are ongoing. Tuesday mornings, anything goes. You can talk about whatever you want. And you can exercise with Shelley on Friday mornings at 9 o'clock Pacific time, and you can figure out where you are in the spectrum here. Email Shelley if you're interested in attending either one of them. And we've got a nice core group, I think, for both of them now. Next. So still the retreat is going to happen. We're still waiting to get some information. World Parkinson's Congress in Barcelona. Ignacio talked to us about it, and like I said, I'm hoping to have Eli talk to us. And if we are still raising money for scholarships for first-timers who are going to the Congress for registration, which is going to be around 400, I believe. If you're interested in going and would like to get a scholarship, please let me know. You can just email me separately. You don't have to put that in the chat. If you're interested in the chat group for Women Without Partners, we're still collecting names. And finally, Stacy Macaluso, who spoke to us a few weeks ago, who was wonderful. She does all kinds of exercise programs. She is no longer with Prime PD, who she was representing at the time. And she has new contact info for her classes. It's stacymaca22@gmail.com. And we can put that, Ashlyn, can you just put that in the chat so people can copy it? And I think that is it. So I will be away next weekend. It's Memorial Day weekend anyway. I'll be in Boston for a wedding, and be back the following Sunday. So enjoy your holiday. If anybody wants to stay on and chat for a few minutes afterwards, you're welcome to.